Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Welcome to this program titled Collaborative Care in Pediatric Atopic Dermatitis, a Multidisciplinary Approach. I'm Dr. Lawrence Eichenfield. I'm a professor of dermatology and pediatrics at the University of California, San Diego, and head of pediatric dermatology at Grady Children's Hospital. Today, we're going to go through a series of modules on the management and treatment of pediatric patients with atopic dermatitis. So let's get started with assessing pediatric atopic dermatitis in clinical practice. So I'll start off with the first question: what are the signs and symptoms of AD in pediatric patients? So we'll start off understanding that there's a tremendous variability in the extent and severity of atopic dermatitis, but there's commonality in terms of the presenting signs and symptoms of atopic dermatitis. Atopic dermatitis, presents with inflammatory eczema, which you can see in the skin as redness, weeping, papules, and plaques. It can be localized in typical areas, and I think we're all aware of the usual classic findings of the signs of atopic dermatitis in younger children. You have a lot of facial involvement, and extensor involvement, but very soon having the classic antecubital and popliteal fossa. And then childhood, which sort of shifts to a mixed pattern of dermatitis with antecubital popliteal fossa involvement, but it can be any part of the body as well. And then as we get to teenage adults, we tend to have more, you can have disease that predominantly present on wrists and hands, face and neck as well. The symptoms of atopic dermatitis relate predominantly to itch, and that's something I like to assess for. And that itch can have a secondary effect of sleep disturbance as well. In looking at eczema, I'm really looking at the quality of the eczema. How red is it? Are there excoriations? Is there lichenification, which shows a chronicity to it? And then I'm also trying to assess the course of the disease, and there's tremendously variable course. And this is very important as a takeaway to which we explain to our patients. It used to be said that most patients would outgrow their atopic dermatitis, and certainly a subset of young children will, over time, have remission or potentially cure of their atopic dermatitis. But there's a tremendously inconsistent pattern in terms of both the time of disease beginning in individuals and its course over time. So there's early atopic dermatitis that persists into adulthood, and lots of variations. So the course of disease can be intermittent or persistent, and that's something I like to assess because the tools I may need to treat the patient may be very different if it's persistent disease that may come under control with topical therapy, but then get bad again when they come off the disease, as compared to very intermittent disease. Now, one of the things we like to assess is the impact of atopic dermatitis on the affected individual, because there's a huge quality of life impact, which is part of the burden of the disease. So I say the burden of the disease is the physical aspect, it's the rashes, it's also the itch, it's the impact on sleep, which obviously can have impact on the activities of daily life, including in pediatrics, school and sports and other leisure activities. And then there's an impact of atopic dermatitis on the caregiver and the family. It's been shown that sleep disturbance isn't just in a child or an adolescent with atopic dermatitis, but can impact the rest of the family as well. My tools for assessing the burden of atopic dermatitis are really a mixed set of tools assessing the extent and the severity of atopic dermatitis. How much of the body's involved? What's the qualities of the eczema? I like to do a body surface area assessment because I've been trained on how I can do that pretty quickly. A hand is 1% of the body. So if someone has 4% of the body involved with localized eczema, it's easy to record that. And I use a general global scale of clear, almost clear, mild, moderate, and severe. In more detailed, more severe cases, I tend to like a little bit more extensive reporting of what the signs may be of the disease. And the symptoms really depends on the age of the child. Often sleep disturbance is the surrogate for how significant itch is, but I will ask families about itch and children about their itch, basically ages 8, 9, or older. I think there's some key questions to ask about the impact of eczema. One of the major ones is what's its course over time and how is it impacting the family? We want to recognize moderate to severe disease as something that really brings more burden with it and may require different kinds of therapy than some of our milder disease. And fundamentally, we're going to translate that to whether we can handle our patients with topical therapies or with systemic therapies. But the conversation really bringing out what the burden of the disease can be, how impactful the disease is, what the signs of symptoms are, and then how it has responded to different therapies, including good skin care, moisturizers, and then different topical therapies, or potentially even systemic therapies in the past, are part of the core questions and answers that we use to assess atopic dermatitis. So, in assessing the signs and the symptoms of atopic dermatitis and assessing the course of the disease, let me be more explicit that one of the things we need to do is to get a sense of what's happened in the life of the eczema for that child or teen before you're assessing that patient on that day. And very importantly, then get a sense of how therapies have mediated signs and symptoms of the disease or not. And then part of the assessment of the course is when you come up with a therapy and have the family do the therapy and then see them back, you'll be looking at the effects of that therapy. But you also have to query, have they done it the right way? Have they utilized the medicine or were they concerned about the medicine? What quantity of the medicine they've used? And then what's been the clinical response that they've seen at home? Because we see the patients intermittently when they come back, but there's a life of eczema that's occurring throughout the time period between our visits. So to really try to get a sense of how the interventions in the past and your interventions impact on the disease in that individual. So in assessing the body surface area, if you're using the hand method, that's fine if you only have a few percent of the body surface. But if you're starting to get more severe disease, you can actually learn pretty quickly how to do body surface area assessment. I sort of train people in the 10, 20, 30, 40 rule. And this comes from what we call the EASY score, the eczema area and severity index of atopic dermatitis. But we take the head and neck as 10% of the body surface area, the arms as 20% of the body surface area, the trunk is 30% of the body surface area, not including the buttocks, and the legs are 40% of the body surface area. So you can look and see if about a third of the head and neck's involved, that's going to be about 3 to 3%. If half of the arms involved, and that's 20 for both arms together, that would be 10%. And the only thing is that for patients under age 8, you take 10% from the legs and you put it up to the head because the heads are relatively a higher percent. So instead of 10, 20, 30, 40, it's 20, 20, 30, 30. But again, I pretty much use that only for moderate to severe disease where you have those more extensive quantities can be very impactful for families over time to show them what the extent of the body surface area and also the improvement. In the next module, Dr. Siegfried will discuss more about advancing therapy in pediatric patients.
Hi, I'm Elaine Siegfried. I've been a pediatric dermatologist for over 35 years and serve as the director of the Division of Pediatric Dermatology at Cardinal Glennon Children's Hospital in St. Louis, Missouri. I want to welcome you to this module on advancing treatment in pediatric atopic dermatitis. First thing I'd like to do is to introduce you to Ken, who I first met in about 2020 when he was 12 years old. He'd been followed, although erratically, by several allergists and dermatologists for severe eczema, as well as asthma and seasonal allergies, managed with topical corticosteroids, courses of antibiotics, and prednisone. This is a picture of Ken. One of the things that doesn't transmit very well for children who have skin of color is the redness, but I can assure you that he was in the category of erythrodermic with a lot of background erythema and then generalized eczematous change. So the first thing I always do when I meet a patient for the first time, really regardless of the severity of their eczema at our baseline visit, is to provide skincare education and very detailed written instructions. This includes daily bathing, and we want to consider, dilute bleach or even hypochlorous acid spray. That's a newer variation that's available online. I use bland emollients, but by the word bland, I mean simple things that don't contain a lot of potential allergens. And then avoiding other kinds of complex products to minimize the risk of secondary allergic contact dermatitis, which we see so often in these kids. I begin with a topical corticosteroid of the appropriate strength, and that depends on the severity of the patient's disease, their age, the extent of involvement. You have choices between, mild, moderate, and more higher potency topical corticosteroid products. When you use a topical corticosteroid, it's really important to dispense an appropriate quantity, not too much, not too little, to help patients guide their use. You can use it up to twice a day, but you don't need to use it more than twice a day ever. And I prefer to go once a day or even every other day for longer term treatment. So typically for someone who has as severe disease as Ken, I'll recommend twice a day for maybe a week, then once a day for a week, and then every other day, with that being the goal for long term treatment, 15 days a month, and then the appropriate quantity a month. So I see patients back. If control is suboptimal using safe amounts of a corticosteroid, that's when you want to add a topical corticosteroid sparing medication. And the great news is the pipeline is really expanding for topical corticosteroid sparing medications. So the first ones that we had were topical calcineurin inhibitors, tacrolimus, which is a little bit more potent than pimecrolimus. Both of those are good medications. Pimecrolimus has propylene glycol in the vehicle. It's just an allergen. That's one that is a common one that causes problems in children who have atopic dermatitis. And the good news about the topical calcineurin inhibitors is that they are, at least tacrolimus is available generically, and you can get it, fairly cost effective. So access is less of a problem than it used to be. Then there's a big category of the phosphodiesterase 4 inhibitors. The original one that was FDA approved, crisaborole, is one that's not incredibly potent, and many children had problems with burning and stinging when it was first FDA approved. So it's been something that's discouraged at least me from trying that one as a first line steroid sparing agent. And then there's roflumilast. That's a new one. That's a wonderful product. It doesn't have propylene glycol in the vehicle. It's very well tolerated. And hot off the presses, it has just received FDA approval in children down to age 2. Very exciting that they're going to have that access. Then there's tapinarof, another new topical medication that targets aryl hydrocarbon receptor. It's a really interesting medication and FDA approved, but not under age 6. And the last one, ruxolitinib, is a Janus kinase or a JAK inhibitor topical. It's only FDA approved in children over age 12, and that's with quantity restrictions. So if you have someone who's got very large body surface area involvement, they're probably not going to get enough to be effective, or there are concerns about the percutaneous absorption. What parameters are important to assess when you're thinking about the burden of treating atopic dermatitis? An important one is a patient and a family's ability to understand and use the topical medication as recommended. I sometimes call that, the burden of topical treatment. It's not easy and it's incredibly time consuming. Another thing that complicates that is corticosteroid phobia, which is pretty common in the general population, and people won't necessarily communicate that to you. So it's an important point to explore with the family. Sleep is one of the most impacted parameters of atopic dermatitis from severe intractable itch, and it's one of the easiest ones to monitor. So I'll usually ask at the baseline, how long does it take you to fall asleep? How many times a night do you wake up? How many nights a week does this impact you? And you can just easily quantify those parameters and follow those over time to assess the efficacy of your treatment for itch in particular. School performance and family dynamics are two other important parameters that are easy to talk about, a little bit harder to quantify. Growth is another parameter that's important to quantify. And what we're finding now is in children who have well controlled atopic dermatitis, they start to grow better. So it's good to always do growth curves for these children and then look at them every time you see them in follow up. Flare frequency is another parameter that you can quantify and document and follow along. Um, it's really important, I think, to assess the associated morbidities, particularly when you're talking about children who can be controlled on topical treatment versus children who need systemic treatment. So I always assess their associated atopic morbidities. That includes rhinitis, conjunctivitis, asthma, eosinophilic gastrointestinal disease, frequency of skin infections. And it's important to note that many of these children are on other types of corticosteroids, so inhaled or eye or nasal sprays, and that increases their corticosteroid burden. So important to be aware of. You also want to assess non atopic morbidities, specifically mental health and learning problems. And then finally, I use a few biomarkers to help me decide about treatment and also baseline disease severity. So total IgE is one that's readily available and easy to measure. And absolute eosinophil count, there is a subset of children who have very high eosinophil levels, greater than 1,500 3 times in a 6-month period of time, helps us define their risk of hypereosinophilic syndrome. So that's another important lookalike for atopic dermatitis that is important to not miss. So, who are the kids that I move on to? Who needs systemic therapy? Well, in general, I just say, those are the ones that either can't use topical corticosteroids as recommended and effectively, or are using too much. For the kids who can't use it, there's so many reasons. Access to a sufficient amount of medication. This is particularly true for corticosteroid sparing products. Just acceptance. Some kids have tactile aversion and they just won't put the topical medications on. They hate ointments or medication burns and stings. Just the ability to understand how to do it. And as I said at the beginning, we give them written instructions that are very detailed and we try to make those as simple as possible. But truthfully, using a safe and effective amount of topical medications when you got two different ones to balance is very difficult for many families. And then, you want to monitor the amount that they're using, because if they're using too little, it won't work. And if they're using too much, bad for you. So I consider systemic treatment for patients with skin disease that can't be controlled with topical medication, especially those who have other atopic associated morbidities. I want to thank you for attending this presentation and hope it'll give you some practical pointers for managing your own patients.
Hello, everybody. I am Dr. Lisa Swanson. I'm a dermatologist and pediatric dermatologist in Boise, Idaho, land of potatoes. I work in private practice at Ada West Dermatology, and I'm affiliated with St. Luke's Children's Hospital. And I'm here to welcome you to this module on updates on advanced biologic therapies for atopic dermatitis. And this is such an exciting topic, you guys, so buckle your seatbelts. We have several biologics available for our pediatric and adolescent patients. We have dupilumab, which works to inhibit IL-4 and IL-13 by binding to the IL-4R alpha receptor subunit. It is approved for patients aged 6 months and up. That's right, we even give it to babies. The dose is based on the patient's age and weight. The shot is given either every 2 weeks or every 4 weeks, depending on how old you are and how much you weigh. Then we have lebrikizumab, an IL-13 inhibitor. It binds directly to IL-13, and it's approved for patients aged 12 and up. It is dosed every 2 weeks for the first 16 weeks. And then one kind of cool thing is that you can space out the shots to every 4 weeks if an adequate response has been seen. Then we have tralokinumab, another IL-13 inhibitor. It also binds directly to the IL-13 cytokine, and it's approved age 12 and up. For adolescents aged 12 to 17, the dose is 150 milligrams every 2 weeks, following the loading dose. And then we have nemolizumab. Nemolizumab is approved age 12 and up for moderate to severe atopic dermatitis, and it is an IL-31 inhibitor, which is kind of cool. IL-31 is known as the master itch cytokine. So nemolizumab kind of tests the theory that eczema is the itch that rashes. So if you treat the itch, you're going to be able to treat the rash. And so we're so lucky to have these four options approved for our pediatric and adolescent patients. And I'm so excited to tell you guys more about each of them. Let's start with dupilumab. As I mentioned, dupilumab has been approved down to the age of 6 months old. We've been using dupilumab since 2017, so it's a medicine that we're very familiar with, very comfortable with. To give you a couple data points, about a third of patients were able to achieve IgA clear or almost clear at week 16 without the use of topical corticosteroids. So, one third of these patients with moderate to severe atopic dermatitis that have certainly been struggling for a long, long time are able to be clear or almost clear at week 16. Pretty phenomenal, pretty remarkable. In addition, another data point that I like to remember with dupilumab comes from the study on the 6 to 11-year-olds. They found that 75% of the patients were able to achieve EASI 75. EASI 75 means that they achieved a 75% improvement in their eczema area severity index. So basically, 75% of the patients got 75% better. This statistic is easy for us to remember, it's easy for our patients to remember, and I find it gives them an accurate sense for what to expect from the treatment. So that's one data point that I choose to include in my conversations with patients and families. Moving on to our IL-13 inhibitors, our selective IL-13 inhibitors, let's talk about lebrikizumab, specifically in adolescent patients. So if we think about the ability to achieve IgA clear or almost clear, we see in their studies that about 46% of patients are able to be clear or almost clear at week 16 with this selective IL-13 inhibitor. In a study where they allowed the combination use of topical corticosteroids, about 57% of the patients were able to achieve IgA clear or almost clear. A couple other cool data points about lebrikizumab. One of my favorite things is that they looked at the amount of topical corticosteroids that patients needed to use during the first year, second year, third year of being on lebrikizumab. And they found that over 80% of patients didn't need their topical corticosteroids through 3 years of being on lebrikizumab. This is remarkable because steroid phobia is at an all-time high. And so if you can tell a patient and their family that with this medication, there's an over 80% chance that they won't need their topical corticosteroid for 3 years, that's pretty darn cool. And I think that's really something that appeals to a lot of patients and their families. The other thing that's neat about lebrikizumab is that it starts out with every 2-week dosing, but if an adequate response has been seen at week 16, you can switch to monthly dosing, which is always nice. Fewer shots always makes people happy. Thinking about itch with our patients on lebrikizumab, because itch is the biggest burden about atopic dermatitis, and so we're really focused on trying to make that better. We look at what percentage of patients are able to achieve a greater than or equal to 4-point improvement in their itch score, which is considered clinically meaningful improvement in itch. And we see in the Lebri studies that almost half the patients are able to achieve that milestone at week 16. If you add in topical corticosteroids, the data is actually quite similar. So in both groups, about half of the patients are able to achieve greater than or equal to 4-point improvement in itch at week 16. And a less itchy patient is a happier patient, that's for sure. Let's think about our other selective IL-13 inhibitor, tralokinumab. How does it perform? So tralokinumab in adolescent patients, if we think about the ability to achieve IgA clear almost clear, we see that about 20% of patients are achieving that through week 16. Now, in this study, topical corticosteroids were not allowed. It was monotherapy with the tralokinumab. A reminder about Tralo. It has 2 doses. For adolescents, it's recommended to dose 150 milligrams every 2 weeks, and for patients 18 and up, it's 300 milligrams every 2 weeks. If we think about how these patients do when it comes to itch improvement, what percentage of them are able to achieve that clinically meaningful greater than or equal to 4-point improvement in itch? And we see about 25% are able to meet that milestone. Let's talk about our last biologic, nemolizumab, in adults and adolescents. Nemo is pretty cool. It works by inhibiting IL-31, the master itch cytokine. It actually binds to the IL-31 receptor. And so with their data points, what we see is we see profound and rapid improvement in itch, achieving milestones such as itch 0, 1 as early as 2 weeks. Pretty darn rapid, especially to reach a pretty high bar metric. Itch 01 means the patient has either no itch or just, oh, that kind of itches. And we know that quality of life correlates with the ability to achieve itch 01. So, this medicine, by targeting itch, is able to reach those milestones in a very rapid way. Now, we've learned with Nemo that it can take just a little bit longer to reach the endpoint of IgA clear, almost clear. And at week 16, about 36% of patients are achieving that milestone. If you give Nemo a little bit longer, the data does continue to improve. So it's important to educate patients that with Nemo, you get rapid itch relief, but it just takes a little bit longer for the skin to clear. In terms of common adverse events that occur with these biologics, with dupilumab, Trelo, and Lebri, these are our IL-4, IL-13, and selective IL-13 inhibitors. The main side effects we see are a little bit of conjunctivitis and a little bit of injection site reactions. With Nemo, we actually see a shockingly low incidence of injection site reactions, only about 1%, which is pretty impressive. And one of the real callouts to Nemo is that it's a very low volume injection. It's only 0.49 milliliters. And the viscosity of the liquid is quite thin. So, of the four I can say from treating patients every day, Nemo is definitely the least ouchy shot. What other adverse events do we see with Nemo? Well, we see a little bit of peripheral edema. It's kind of interesting. We don't see that with the other biologics. And we see a little bit of an asthma signal. In the phase 3 studies, they actually had an asthma adjudication committee come in and look at the data for Nemo. They ended up concluding that there was no asthma signal. However, patients with severe asthma or who had had recent hospitalization or episodes of asthma were excluded from the study. So if I see a patient who also has asthma, I might choose one of the other biologics as opposed to Nemo because of that information. We are looking forward to having biologics approved in the younger space. The only one we have approved under 12 is dupilumab, and we're grateful for it. But we're excited because ongoing studies are in progress for lebrikizumab and tralokinumab, and it'll be so nice to have additional choices in this younger patient population who's really suffering with a lot of moderate to severe atopic dermatitis. Now, you guys are in for a real treat because your next module is about primary care to specialty care pathway with Dr. Peter Leo. I hope you enjoyed this session, and I hope you look forward to Dr. Leo's session.
Hi, I'm Dr. Peter Leo. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University, Feinberg School of Medicine in Chicago, Illinois. Welcome to this module on the Atopic Dermatitis Network of Care, primary care to specialty care. We know that the breakdown of severity in atopic dermatitis really does range throughout all ages in pediatric patients. Even though we often see babies who are more severe, we know it can affect the whole range. And this is something that is global. At the very least, we have excellent evidence that in North America, Canada, the United States, and Mexico, we can really see quite a spectrum of disease from mild to moderate to severe, and this really can affect all ages. Of course, more mild and moderate patients are more common, but there's still an awful lot of severe disease, and no matter how we slice it, all of these patients suffer. When and which pediatric patients with atopic dermatitis should be referred to specialty care? This is a really important question because we understand that on the order of half of all patients with atopic dermatitis, and in some places probably far more than that, are actually treated exclusively in the primary care setting. We are very protective of the dermatology diseases in dermatology and to some degree within allergy, but we understand that we literally do not have the workforce to treat everybody. And it's so important that primary care physicians and pediatricians are comfortable doing this. However, there also are points where it makes sense for them to refer to a specialty center. When should a PCP be referring a patient to specialty care? What is their continued role in treatment? I think these are really important questions. And of course, it can vary from person to person and case to case. But in general, I think a good answer is when a patient is not doing as well as we hope, or a patient has questions where the PCP or pediatrician feels that they've now gone past their level of comfort. And it's really important because we understand there are some pediatricians and primary care physicians and practitioners who are quite comfortable with atopic dermatitis and are capable of managing a wide range. Others are less comfortable, and that's okay. It's just one of those pieces where we say, okay, this is not working anymore. We're going to reach out. And the truth is, that's even true to some degree within specialties. Within dermatology, there are certain conditions I'm much more comfortable with than others. And I might say to a patient, I'm going to refer you to a colleague. So there's no shame in that. But continued treatment is very important because we understand that we need to have this communication throughout the treatment journey. If the pediatrician or the primary care provider is not on board or not following, that can be detrimental to everyone. And I really like this idea of therapeutic alliance, or another way to say it is therapeutic alignment, where we're all agreed and coming together. That's so important because sometimes I've actually seen where one specialist is arguing with another, they disagree, or when the primary care provider disagrees or doesn't seem to follow along with the reasoning of the specialist. And this is disastrous for the patient and their family because now they're sort of left in the middle of this argument. It's so important that we all understand what we're doing and why we're doing it. Ideally, the patient as well. We want to make a shared decision-making approach so the patient and their family are part of the discussion so that if and when the primary care provider or pediatrician says, well, why did you pick this? They can say just comfortably, this is why. When they're not sure, or when maybe they're not as comfortable, it's so important that we get together and talk. And to many patients and families, I say, listen, if your pediatrician has questions, let me talk to them and we'll go over why we're doing it. And again, it's not just a one and done. We're going to continue this dialogue throughout the treatment course. And for some patients, it could be years. Ideally, after the first few discussions, the pediatricians feel very comfortable. They understand where we're coming from. They're on board. And then they say, okay, I got you. I understand where you're coming from. I understand your thinking. So please proceed. You don't have to keep me updated beyond sending your notes and calling me if you need anything. And that's really exciting. How do you work through warnings against specific drugs by the pediatrician or primary care? Of course, many of the things we use can have serious side effects, from our systemic agents that have all sorts of things we have to discuss, but even our topical agents, some of which have true boxed warnings from the FDA. All of these are important, and it's so critical that the patient is aware and comfortable with them and that they understand. It's also important that the pediatrician or primary care is on board, because the worst thing that can happen is if the patient doesn't feel like they understood what we were talking about. Then they bring it to their pediatrician who says, wait a minute, this is dangerous. I don't want you using that. We absolutely don't want that to happen. It's so important that everybody's on board and understanding why. Some of the situations that come up, for example, with our JAK inhibitors, the topical JAK inhibitor, that actually has a boxed warning and it has some scary language in there. So I like to make sure the patients understand what that language is, because the pharmacist also might bring it up, why I still think the risk benefit profile is worth it, and where it comes from, to explain that really it was built in that particular instance based on evidence from an oral trial that was used in rheumatoid arthritis patients in a different disease state, specifically rheumatoid arthritis. So I really like to make sure they understand that whole story so that they feel comfortable. And if they're not comfortable, then I'm not comfortable, so we won't go there. Continue on to the next module to hear about best practices in shared decision-making for atopic dermatitis.
Welcome. I'm Dr. Adelaide Hebert from the University of Texas Health Science Center in Houston, Texas. I'm happy to welcome you to the module on best practices in shared decision-making for atopic dermatitis. There are a number of things that must be considered when one begins to consider shared decision-making, and we're going to cover a number of these entities this evening. First and foremost, we need to talk to our patients and parents regarding what will work for them. We know that there are preferences when it comes to treatment. Do they prefer a topical or a systemic? Is there something they don't wish to use or simply will not use? We need to think about a systemic versus an oral versus a topical, or a combination of therapies to make the best practice choice for this particular patient who sits in front of us in our practice on a given day. We also need to know about which systemic agent might indeed be the best choice for that particular patient at this time. We're very fortunate that we have some new, very advantageous medications that have come onto the marketplace to allow us to have choices when we think about systemic agents in the management strategy for atopic dermatitis. We also want to think about risk-benefit profile. How will we share this information with our patients and our parents? We know that every medication, even if it's topical, may have some side effects. We can't be glib about these issues. Certainly with some of the systemics, let's say we have to give an injection. In our younger patients, that can be a tremendous challenge, but we also have adults who feel very negatively about receiving ongoing injections, even if it would mean control of their atopic dermatitis. Another consideration which must be taken into account is adverse events. Could this patient develop, let's say, conjunctivitis, an injection site reaction, or other issues which may cause concern? Are those adverse events manageable, or will they actually preclude that patient going forward with that particular medication, at least at this time? We also want to look at the totality of the patient. We need to think about the efficacy of the medication as well as the impact on that patient's quality of life. We're very fortunate that we have choices that can allow very favorable impact on quality of life in today's treatment strategy armamentarium. We also need to think, particularly in the pediatric realm, about patients being able to sleep and being able to grow. We know that if these children don't sleep effectively, they tend to have impaired linear growth, and they don't really have the optimized day-to-day activities, for example, at school, or if they're going to camp, or taking lessons outside of school. So we want to be sure that we take these considerations into account as we plan our strategy for therapy for any given patient at any given time in their course of atopic dermatitis. One of the things we want to also give some thought to is how are we actually going to have this discussion? How are we going to bring up these multiple elements of a shared decision-making plan when we have to talk about choices, sleep, itch, quality of life, systemic versus topical? We have a lot of things to consider as we go forward with our own plan for the patient and hopefully sharing the decision making with the patient or parent while they're in front of us in the clinic. We must give consideration to the education, as I believe this is truly the cornerstone for success, regardless of whether one chooses a systemic, topical, or an oral medication in the management strategy for atopic dermatitis. One can consider written instructional materials or putting those perhaps on your web page. We often hear about management plans. These often entail acute flare management as well as long-term strategies to prevent future flares. We know that we have to discuss acute management and chronic management as part of our overall plan when we give instructions to patients and parents. We know that handouts can be a huge benefit and can provide guidance as well as reduce callbacks or even confusion. We don't want the patient or parent using the medication in the wrong way, and we want them to derive the benefit that these new medications actually offer. We also want to set up very realistic treatment goals and a time frame for expecting improvement in the atopic dermatitis arena. This is particularly true if the patient has had a flare, particularly a significant flare of atopic dermatitis. We need to get the disease under control and think about possibly proactive therapy in order to maintain a strategy of success in keeping that atopic dermatitis under control. We need to also discuss when we would like to see that particular patient in follow-up. I tend to see the most acute patients back fairly soon after the initial visit to make sure that the treatment plan is actually going forward in a favorable way. When I've had patients under my care for quite some time, I can often extend the time between visits when I feel the patient or the parent is managing their disease very effectively. Telemedicine has undergone some recent changes. We know that our patients that fall within the Medicare realm may or may not be able to use telemedicine going forward. Also, depending on the insurance coverage in any given state or interstate practices, We can use telemedicine for some patients, but indeed not for others. We certainly have to have discussions regarding using combination therapy with topicals and biologics, with special care and consideration given to the fact that some topical agents can actually preclude the use of a biologic because we will lose the authorization that we have from the insurance company providing that medication for the patient's atopic management. We have so many arenas to consider when we go through the process of shared decision making. I hope that a few of these constructs help you to decide how best to have the discussion with your patient or parent going forward to manage effectively their atopic dermatitis. I want to thank you for attending this session, and I do hope this educational program will help you as you go forward to establish a treatment plan for those patients for whom you provide care.
So overviewing the program, you can see that we've taken an approach to look at atopic dermatitis in pediatric patients and went through the sort of basic core knowledge of atopic dermatitis and the variable course, but also very importantly, the assessment of pediatric atopic dermatitis patients. We want to get a sense of the extent of the disease, the signs of atopic dermatitis, what's the quality of the eczema, what's the extent of the eczema, how much of the body is involved. We want to get a sense of the chronicity of that because we're just looking at the signs at that particular time. And of course, the symptoms of atopic dermatitis. Uh, Eczema has that profound itch associated with it. The itch is tremendously variable. In our older children, we may be doing itch assessment on a 0 to 10 score. In younger children, we're using the parents as a surrogate to tell us about how significant the itch is, and very importantly, how that translates to the impact on the individual. We're assessing the burden of the disease, and that could be a mixture of using really questions about the impact on quality of life. I tell people it may be sort of unpacking the backpack of the issues with atopic dermatitis. We want to assess sleep disturbance. We want to assess impact on daily activities, impacts on sports, impact on going outside, impact on school performance. We want to look at the impact on the family as well. We recognize that we have a set of therapies in atopic dermatitis, and these include topical therapies, but also systemic therapies. And certainly it's a relatively new thing for us to have more liberal use of systemic therapies for atopic dermatitis in pediatric patients because we have a selection of therapies that have an excellent efficacy and safety profile associated with them. So recognize when a patient can advance to systemic therapy is very important. Recognizing that they've had insufficient control of the disease, a burden of the disease that's not being managed with topical agents, a course of the disease over time that's impacting the individual and the family. Now we have a set of advanced systemic options for pediatric atopic dermatitis, variable depending upon the age of the patient. So we have a IL-4 alpha blocker that blocks IL-4 and IL-13 that's approved in younger children, and that includes patients under age 12 years of age down to 6 months of age with dupilumab. We have a variety of agents that block IL-13 that are available in our teenagers. In addition to dupilumab, which is also approved in adolescents and adults, that includes lebrikizumab, tralokinumab, nemolizumab, which blocks IL-31 as well, and oral JAK inhibitors, all abrocitinib and upadacitinib, which are oral agent alternatives in our teenagers. So there are these advanced systemic therapy options that we can bring with an evaluation of the patient's past and potential course and shared decision-making on which agent to use or whether to use these agents in appropriate patients. I think it's important to recognize that because we have these multiple agents that we use over time, it may outstrip what a primary care practitioner, a pediatrician or family practice doc would like to do in their clinical practice. I don't really expect them to be experts in advanced systemic therapy for atopic dermatitis. So figuring out from a community standpoint, who's the expert who you can use for referral, whether that be a pediatric dermatologist, a dermatologist who takes care of children but comfortable with these decisions, or pediatric allergist, sort of know what your community resources are for specialty care of a pediatric atopic dermatitis, including the systemic options. And lastly, understand that whether you're a specialist or a primary care doctor, it's very important to um, approach the decision making of management of atopic dermatitis with both knowledge and an open mind, with shared patient decision making with patients and the families as they figure out what's the appropriate therapy to keep that child in a different state to minimize the impact of eczema on that individual and the family over time. Thank you so much for joining our programs.